Hello, I'm Susan Wang, a pediatrician and an internist. Currently, I'm an Associate Chief of Science at the U.S. Centers for Disease Control and Prevention. I'm very excited to talk to you today about my WomenLift Health Leadership Project entitled Enhancing the Diversity of Global Public Health Technical Advisory Groups. I came to this topic as a result of my work at the World Health Organization in Geneva, where I had the experience of supporting working groups and technical advisory groups of all kinds for disease burden assessments, international health regulations, reproductive health, but particularly for development of vaccine policies and vaccination strategies. Global public health organizations such as WHO, Gavi, the Global Fund, and the World Bank frequently make use of external technical advisory groups, or TAGs, to review and frame public health problems and to provide advice on strategies, policies, and solutions. Having a seat at the table by being a TAG member means having a voice in articulating the issues and in shaping the solutions and recommendations of these global organizations. So what is the issue? The primary issue is that members of TAGs do not consistently reflect the diversity of the populations served by the global health organizations or the extent of women working in public health. Often, external experts in TAGs have similar pedigrees in terms of where they went to school, where they did their training, and where they have worked. TAGs would benefit from having a little more variety. Underlying the first issue is the second point. The pool of candidates from which TAG members are selected is often small and lacks women in diversity. We need to remove the barriers that keep women and persons from low and middle income countries from more readily and much more abundantly entering the candidate pool for selection to a TAG. I hypothesize that there may be two areas of potential barriers to having a diverse candidate pool. First, there may be institutional barriers, such as limited dissemination of calls for nominations. Institutions are not reaching a broad audience to successfully create a large candidate pool. Second, there may be candidate barriers. For example, a lack of familiarity by potential candidates regarding the role and the work of TAGs, and perhaps the lack of knowledge that to become eligible to be on a TAG, a person needs to self-nominate. Insights on barriers and solutions need to come from stakeholders. So I undertook numerous conversations on this issue with TAG members, organization staff members, and global public health professionals who could be potential candidates. I also put together a survey with the support of WomenLift Health, which was distributed via LinkedIn and to WomenLift Health cohorts, as well as to mentors, allies, and the board. Survey takers were asked to share the link to the survey with their network so that survey distribution could be amplified. Of the 106 responses received, 90% were from women. Most respondents had over 10 years experience in public health, but at the same time, most were not familiar with how TAG members were nominated. Survey respondents shared a rich array of additional ideas about possible barriers to the inclusion of women and persons from low and middle income countries, or LMICs. A sample of the responses is on this slide. I'd like to highlight three barriers. One, institutional preference to interact with people they already know. Two, lack of support from the LMIC institution where the person works. And three, since TAG work is additional to one's regular job and is generally not remunerated, potential candidates may be discouraged by lack of time, funding, or childcare to allow for TAG work. So what next? My leadership project thus far has been exploratory. Thus, there is a need to more broadly collect inputs. But some initial ideas of practical steps to consider implementing include: publish a paper on this topic to highlight the need for intentional actions by institutions, create a central clearinghouse website to post nomination calls from multiple global public health organizations. This could be a win-win for both the institutions and for potential candidates. Institutions often don't have the bandwidth to extensively circulate calls for nominations, and potential candidates would be able to reliably and regularly go to one website rather than multiple to learn about opportunities. Create a Global South public health expert database. I learned that there already exists a Global South database of experts for health system strengthening. Perhaps that could be a model for expanding to include other expertise in the database. Raise awareness among potential LMIC women candidates of the roles that tags play for the global public health organizations and of the necessity of self-nomination. Mentor early career LMIC public health professionals and offer opportunities for short-term roles supporting tags. This leadership journey has given me important insights about leadership, of who I am as a leader and how I can continue to grow as a leader. The concept of authentic leadership made me appreciate that good leaders come in a variety of sizes and shapes. There's not one single mold that every leader needs to fit into. My strengths and values are that as a leader, I am curious, and I lead in service of collaboratively achieving impact. Inclusive leadership is the fun, interesting, and exciting work exemplified by this project. Seeking and including new perspectives and creating new connections leads to collaborations and cross-disciplinary work, which hopefully will break new ground and find new solutions. Having strategic leadership is taking those new solutions and figuring out how to make them a reality. It is future-focused and change-oriented. An impactful leadership is leveraging insights to make connections that inspire action and lead to meaningful and lasting change. These aspects of leadership have come into play during this exploratory phase of my project, and I'm sure they will be vital to take the project forward in order to change the status quo and make a difference. I would like to thank the WomenLift Health leadership team and also express my great appreciation to my 2022 WomenLift Health cohort, who energize and inspire me. I send a shout out to the current and past U.S. cohorts, as well as their sister cohorts in India and Africa, mentors, allies, the WomenLift Health Board, all of whom were so generous with me and responded to my project survey. Thank you very much.